And great. Okay. So fluid management, part one, lots and lots of fluids. This is broken up into 3 parts because it's like I said, it's a very complex issue. I tend to like that slide. Soak it in. So the principle of fluid therapy is to maintain tissue perfusion. Common crystalloids that we see all of the time, of course, are normal plasma. First is the most prevalent within the body, but 0.9 sodium chloride, you could have half normal saline, you could have quarter normal, you can have 5% dextrose in water. You can have plasmolite. Of course, that's very popular for perfusion, prime normosul and plasmolite. Hartmann solution, which is very similar to lactated ringers. Both of those use lactate as a buffer. And all of these are, or most of them are acetate-based solutions for pH adjustment, particularly the plasmolite. Okay, so that's very important. Actually, the plasmolite is acetate-based, and that's used for pH adjustment. But it says pH 7.4, but it can be anywhere from 6.5 to 8. So that's kind of a little bit of a confusing thing there. And if you give a lot of it, you're diluting the bicarb out. But we'll talk more about that as we move forward with the presentation. There are also bicarb-based fluids. Now, this happens to be Duosol, which is made by B. Braun, but Baxter has some. Baxter has some, Next Stage has some, and stuff like that. The difference that you see here is none of them contain lactate. All of them contain bicarb. All of them have normal sodiums. You can see there's variability in the potassium. Some of them have 0. Why would you use a 0 potassium solution? Why would you use a 2K solution? Why would you use a 4K solution? And I can explain that. They all have magnesium except for, all of them have calcium except for the 0 calcium solutions. And there's a reason why you want to have that. Magnesium, they all have magnesium, chloride, and 3 of the 6 have glucose in this case, and their estimated osmolality is pretty much, normal, okay? Similar to that you would find in plasmolite. So they're isotonic solutions, all of them. With that said, the reason you would have 0K potassium is these are used predominantly for dialysis. And they are a little bit more expensive. Like this is probably costs, let's say the 4551, the very top one, it's gonna cost about $20, $22 for a 5-liter bag. So that equates to about, somewhere in the neighborhood of what, $4 a bag, 4 to a little over, where it costs about $2.30 for a 1-liter bag of plasmolite. These come in 5-liter bags. So it's not really, it's about double the price is about what it's going to cost, right? So that's I think what the issue is with these, plus they're 5-liter bags. They're not very convenient. But nevertheless, I think they're better in a lot of ways than what we use with saline and plasmolite, especially if we're doing ultrafiltration on pump, which I like to do a lot, whether it be zero balance ultrafiltration or just ultrafiltration for plasma water removal, all right? I want to talk about the physiology of fluid and fluid balance, properties of common IV fluids, and a practical fluid balance approach. So in normal physiology, this is basic stuff. We all know this already, but just as a reminder, the distribution of total body water. Total body water is 42 liters plus or minus, which is roughly 60% of body weight. Intracellularly, it's going to be about 28 liters. Extracellularly includes intravascular space. That's going to be about 14 liters. And in that extracellular, 11 is interstitial and about 3 intravascular. Obviously, it's more than that depending on your weight and various different things. My intravascular fluid volume, it's probably about that, not including cells, all right? So I think you take that into consideration. That's water weight. Composition of these fluids, we already know all of this, all right? So you can see the sodium, potassium, calcium, magnesium, chloride, bicarb, sulfate, hydrogen phosphate, and proteins. And so you have cations and anions and blah, 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 blah. We all know all this stuff. Daily fluid and electrolyte requirements, we need about 2,500 milliliters of fluid a day to survive. Our requirement for sodium, however, is about 0.5 to 1 millimoles per kilogram per day, and potassium is about the same. But on the sodium level, that is basically about, for me, my size, I weigh about 100 kilos, that is pretty much a bag of chips. A bag of Lay's potato chips, and I've reached my daily sodium limit. So I definitely exceed it. There's no question about it. A colloid, of course, has protein like mass, and a crystalloid is just an ionic solution. Again, basic stuff. Crystalloids and colloids. This is a very, I think, important slide. Intravascular persistence and crystalloid is very poor. Colloid is very good. In the category of hemodynamic stabilization, crystalloids are very transient, where colloids are more prolonged. In the category of required infusion volume, crystalloid is very large to get the desired effect, and colloids is only moderate to get the desired effect. Risk of, that's important. If you've already got a heart that's at the top of its Starling curve and you're having to give volume because you're right heart failure, for example, giving a moderate amount to increase the volume load is going to be better than giving a larger amount. It may not be a great example, but I think you understand where I'm coming from. Risk of tissue edema. Well, with crystalloid, it's obvious. And I put obvious there because it is obvious. Insignificant if you use colloids. In fact, I think I should have put improves versus then insignificant. I think I made a mistake there. Enhancement of capillary perfusion with crystalloid is poor. With colloids, it is good. And I'll show you some data to support all of this. Risk of anaphylaxis does not exist with crystalloid. It's low to moderate depending on the colloid used. With albumin, it's very low. With stuff like Hespan, the starch, the gelatins, that kind of thing, it's going to be low to moderate depending on which one you use. And cost is relative. Crystalloid inexpensive, colloid is expensive, but it's inexpensive. Again, $230 a bottle of normal saline, and it costs about $40 for a 50 cc bottle of 25% albumin. So that's what that costs. So for 25 grams, you're getting a big impact. And is that expensive? It's more expensive, but is it expensive? I think that's a relative term. Sometimes I think we nickel and dime the wrong stuff. And I'll explain why I say that. But persistence of fluids in the circulation. Well, with crystalloid, the half-life of crystalloid, we talked about half-life on Tuesday, so you could figure this out, all right? Persistence of fluids in the circulation with crystalloid is about 30 minutes, and with colloids, it is 90 minutes. So 3 times the number of, or three times the length of, in terms of duration of effectiveness. So this is very interesting. If you infuse 0.9 sodium chloride, a liter of it, all the sodium will remain in the extracellular fluid compartment. However, Sodium is isotonic. There's no change in the extracellular fluid osmolarity or osmolality, and no water exchange occurs across the cell membrane, intracellular to extracellular. Sodium chloride expands extracellular fluid only, but this is the kicker. Intravascular volume will only be increased for that liter by 250 cc's because of redistribution from the intravascular space back into the extracellular space, what we call third spacing. And it happens fairly quickly. So something to keep in mind, all right? Let's see, let me go back here. I like this, I like camera one. Plasmolyte, crystalloid, it's a crystalloid, it's a first-line fluid. It's used to expand intravascular fluid space, essentially what is the extracellular fluid space, but intravascular, and it is isotonic. I'm sorry, hold on one second. Anything, guys? No? Okay, I can keep going? Okay, I can keep going. Gelatins, we talked about that. And gelatins, you know, I don't know that we use gelatins that much here in the United States. In fact, I don't even think we do. They may in Europe still, but that really came from bovine collagen and was first discovered in like 1915. And it wasn't used extensively in World War I, but it was used extensively in World War II. So, but I think now we use more of the starches versus the gelatins. But it's a colloid. It is an effective volume expander. It has a moderate intravascular life. It has some anaphylaxis, and its molecular weight is 40,000 Daltons. Now, albumin, on the other hand, has a molecular weight of 62,000 Daltons. So it's much, much larger. So if you're doing, let's say, CVVH with a CRRT machine, continuous veno-veno infiltration, you will remove gelatins and probably some of the starches too, but you won't remove albumin because the cutoff on the filter is 50,000 Daltons. Let's see. Oh, I hit the wrong button. So practical fluid therapy, well, let's talk about replacement of intravascular volume. Let's talk about maintenance therapy, and let's talk about replacing electrolyte deficits. So if you are intravascularly depleted of volume, first you get 5%, you're going to get very thirsty, dry mouth, and your urine output is going to decrease significantly. At 10%, you're going to be tachycardic, you're going to be oliguric with a urine output of 0.5 to 1 milliliters per kilogram per hour. But if you lose 15 to 20% of your intravascular fluid volume, you'll be very tachycardic, you're going to be hypotensive, you're going to have severe oliguria, and you're going to feel bad. And that needs to be treated. And that can happen in a variety of ways. I think we look at this model of hypovolemic shock, and we think about it in the context of a car accident, shooting victim, some kind of trauma of some sort, but we don't think about it in regards to the pump. I'm going to show you an animation that I made to show some interesting stuff. But when we go on bypass and we drain the right side of the heart completely, there's going to be a reaction to that. And it's interesting to watch. Now, there's a lot of reactions that are occurring because depending on whether you wrapped or not, heaven forbid, everybody knows I hate that, whether you ultrafiltrate, you see with the amount of hemodilution, you see different things happen. You can get mostly we see hypotension. And we don't really even see that much tachycardia, but that could be because they're beta blocked because anesthesia is doing a good job. And the few times that I'll compliment anesthesia on this program, but I'm going to tonight. Nevertheless, there's a lot of different things that do take place. So do we use plasmolyte or do we use colloids? Do we use crystalloid or colloids to restore perfusion? Well, we need to consider hypotension, tachycardia, oliguria, cool peripheries, and known blood loss. We need to know why and what's happening with the patient at the time, because at the end of the day, from my earlier slide, fluid replacement has to do with restoring perfusion to the tissues. So control of the volume status, effective circulating volume, a portion of the extracellular fluid that perfuses organs, and usually equates to the intravascular volume. So your effective circulating volume is your intravascular fluid volume that's getting pumped around by your heart. The third space, loss, is an abnormal shift of fluid from the intravascular space to the tissues, such as you would find in hypooncotic or hypoosmotic states. So when we give fluids, we want to know the type of loss, the degree of the deficit. Is it a blood loss or is it a fluid loss like you would find in a burn? Comorbidities, and what the response is to replacement while we're doing the replacement. So you want to know those things. So in summary, you need to assess and you need to reassess. Use salt-rich solutions to resuscitate. You do that because you want to increase the osmolality or at least keep it stable. The last thing you would do is give water to someone who is volume depleted. That's just not going to be very helpful. Use water plus sodium potassium for maintenance. Blood if they are actively bleeding and or anemic. Beware of hyponatremia and hypernatremia. If you do modified ultrafiltration, I didn't mean to do that. Let me go back. If you do modified ultrafiltration on pump and you're pulling off a liter, giving back a liter, pulling off a liter, giving back a liter, pulling a liter and giving a liter of 0.9 sodium chloride, then you are going to not only dilute the bicarb down, but you are going to become hypernatremic. Now, sometimes a little hypernatremia is not bad if you want to keep fluid in the intravascular space. I think colloids is a better way to do it, but that certainly is a technique you can use. You can also use, if you wanted to raise it up a little faster, you could use 3% saline. But you have to be cautious because, we all know the stories about drinking seawater and how sick you get. So making someone grossly hypernatremic would be a bad idea, all right? So let's move right into part 2, fluid balance and why we pee. And I hope, while I'm kind of waiting to go over this slide with you all, I hope somebody calls in, and you can call in at any time and interrupt the slides if I get to a point where you go, man, I really want to make a comment, because I've got behind me here the YouTube chat, and I try to watch that, but I can't watch the YouTube chat and the Facebook chat and the Twitter and everything else at the same time. And so that phone is really, really, really helpful for me. It makes it a lot easier for me if you just call in if you want to. And I enjoy the phone calls. I love talking to somebody. I'd love to talk to somebody. Let's see, where are we at here? Okay, so the glomerular filtration rate, or GFR, depends on diameters of the afferent and the efferent arterioles. And if you look at the slide, you have in the middle the glomerulus, to the left is the afferent, and to the right is the efferent arteriole. And you'll see underneath afferent increased GFR by dilating the afferent arteriole, constricting the efferent arteriole, different things like prostaglandins, kinins, dopamine, low dose. Why do we give 3 mics of dope when we're on pump or in the ICU and the patient's not making as much urine as we want? Well, we do it because it dilates the afferent arterial artery, the arteriole. And then nitrous oxide, of course, that would also help. And on the contrast, if you constrict the afferent, dilate the efferent, because now you've got not the same pressure gradient. And I'm going to show you a slide about that I think sort of explains it in a more almost mechanical way. This is pretty simple to understand, though. Lower pressure on the inside, and because of constriction, and then you have a lower pressure on the outside, you want that pressure differential. You want the outlet to constrict a little, the inlet to dilate to let more blood through and let that pressure head go up. So the pressure differential through the glomerulus is higher or greater so that it goes through. But the various different things that you can do, angiotensin II in high dose, noradrenaline, endothelin, ADH, which is antidiuretic hormone, will constrict the afferent arteriole. So when we give vasopressin, vasopressin is ADH. And so that's exactly what's going to happen is you have a decrease in urine output when you use vasopressin as a blood pressure giver. So when you're hypotensive and you're treating that hypotension with vasopressin, you have to pretty much assume and expect that you're going to have a decrease in urine output as well for that reason. Conversely, if you give an angiotensin II blockade, the opposite occurs. You dilate the efferent. Either way, it's the opposite of what you want. And then you have the natriuretic peptides, which are involved in long-term regulation of sodium and water balance, blood volume, and arterial pressure. There are two major pathways of the natriuretic peptide actions. One is a vasodilatator effect, and the other is a renal effect that leads to natriuresis and diuresis. Okay, so natriuresis being the loss of sodium and the water along with it. Cardiovascular and renal actions of these natriuretic peptides that live in the right atrium and the right ventricle are natriuresis, diuresis, improved glomerular filtration rate and filtration fraction, inhibit renin release, decreases circulating angiotensin II, decreases circulating aldosterone, systemic vasodilatation, arterial hypotension, reduced venous pressure, reduced pulmonary capillary wedge pressure. So these have an effect. And what I was mentioning to you earlier is that when we go on pump, again, going back to, I'm going to show you that simulation, which I think is just so cool. And David Sullivan is the one who created it for me and took him like 3 or 4 hours, and it's really neat. But so I think you'll enjoy watching that. But it'll illustrate my point. We empty the atrium out. We empty the right atrium. We empty the right ventricle out. It's completely flaccid. It's empty. Sometimes if you're using vacuum assist, it's under negative pressure when the line is jumping, and we have chatter in the line. So what does that do to the stimulus for the natriuretic peptides that exist, that the nerve endings, nerve cells that are there to sense that pressure that affect what our urine output is. And it affects it by slowing it down. So is it the ultrafiltration on pump that reduces the urine output, or is it just the fact that we're on pump? Now, of course, you could argue, is it continuous flow because we don't have pulsatile flow, but the places we use pulsatile flow, I don't think have better urine output, at least I don't think so. And of course, if you talk to Dr. Cohn or Dr. Frazier, they'll tell you that pulsatile flow is completely useless. You just need a good mean pressure to perfuse everything, that the pulse really doesn't do anything, it's just how we're built and how the heart happens to work effectively. I guess God couldn't create it so that it just spun like a centrifuge. Oh. I like that new feature pool. Great job, David. Oh, Stephanie said something. That's great. I like it too. I haven't seen it though. Okay, I messed up. Let's go back. What am I doing here? Help me out, somebody. Let's see. Man, I'll tell you what, guys, this is tough. Oh, okay, I was already there. So, yep, that was the slide I wanted to show you. All right, so if you look at this slide, this is not that dissimilar to a kidney and our fluid replacement. The red is taking the blood from the patient. So let's just say that's the big renal artery. It's going through a kidney. It's removing fluid, plasma, water, everything up to 50,000 Daltons, so 49,999 if you're using convective clearance, and I'll talk a little bit about that here moving forward. And that's how you remove the fluid. But then you'll see there's a dialysate, which makes no sense at all. The post-filter replacement, now that makes sense. The pre-filter replacement makes sense if you're trying to maintain if you don't have good anticoagulation, but I'm not going to worry about that either. Let's just focus on the lower right section, which is the post-filter replacement. And we'll call that the IV. We'll call that the bottle of Gatorade. We'll call it whatever you want. Because basically what's happening here is you're removing fluid from the plasma, you're removing water from the plasma, and you are replacing it with a fluid like with what has in it what you want the plasma water to look like. I hope that makes sense. Maybe I didn't say it. Let me try to say that one more time. You're removing plasma water and you're replacing it with a fluid that is the constituency of what you want the plasma water to look like. So, for example, if the potassium is 9 and you are removing plasma water with a potassium of 9, but you're giving an IV back with a potassium of 2 or 4 or 0 to get it down even faster, you're going to remove fluid, because remember, whatever comes out is always going to be isoosmotic. So whatever the blood plasma water is will be what's in that effluent down at the bottom left. So you can alter the electrolytes of the blood, not just the concentration of red cells or the dilutional effect of it. You can manage concentrating it through ultrafiltration, but also by doing a replacement, you can affect the electrolytes as well. And that's a very, very important concept of CRRT, but it's what the kidney does. No, keep hitting the wrong button. Hemofiltration, convective or solute drag. Now this is very important. If you look at this, the yellow side is the waste side, the red side is the blood side, membrane in the middle. And it says on the bottom, low pressure, high pressure. So it's a high pressure to a low pressure. So I want you to think of the high pressure as the afferent arteriole, and I want you to think of the low pressure side as the efferent arteriole. So as the blood goes up, think of it as the glomerulus. Think of the blood in part of it as the efferent. So the blood in is the afferent, the blood out is the efferent, going back to the patient, and the glomerulus is the whole thing, and then you have the bladder, okay, you're putting the urine out. So if you make the pressure on the blood out higher, or the resistance, rephrase that, and you make the blood going in a lower resistance, then you have a pressure gradient inside there that forces the fluid through the membrane and then out to the waste. And then you can put the replacement fluid either pre or post. So I hope that made sense. I hope it did. If it didn't, call me. And then there's crosstalk. Kidney injury is an interesting phenomenon. And again, I think it's one of those things that is very underappreciated in the perfusion world and in cardiovascular medicine as a whole. When we go on pump and we have low pressures, we have to turn the flow down for various reasons. You got to get through the operation. But there's a lot of things that cause acute kidney injury. I'm a little bit uncomfortable with the STS parameters for determining acute renal failure. You know, I do think that if you have a 50% jump in your serum creatinine level, that's something to be concerned about. I think it's an injury, but I don't know that I would call that acute renal failure. But you know, renal failure rates by STS in cardiac surgery are pretty high. They're up around I want to say 30%, whereas requiring dialysis is down around 4%. So there's a big, big, big difference. If you don't require renal replacement therapy, then in my view, I don't think it's reasonable to call some of these things failure, but they do. Nevertheless, there is a lot of crosstalk. The kidney is a very undervalued organ. We just don't think about it. But man, it has a tremendous effect on so many things. You have in the brain increased vascular permeability. You have various different interleukins, interleukin 8, and these various different cells, which are the microglia cells and glia cells, which are markers for inflammation, biomarkers for inflammation. The heart, you have an increase in TNF alpha and interleukin-1, neutrophil trafficking. You have apoptosis, fractional shortening in the bone marrow. You have suppression and anemia, coagulation disorders, and immune dysfunction. The lungs, increased vascular permeability, which results, and of course, leukocyte trafficking, all of which result in stiffer lungs, wet lungs, pulmonary edema, and so forth. The liver, you can see there, leukocyte influx, oxidative processes, and decrease in antioxidants. All of these affect that. And the gut, again, gut gets edematous and doesn't want to work quite as well. So the crosstalk between the kidneys and so many different organs. There was a nephrologist internist that I used to work with. His name is Luis Juncos. He was, the last I heard, was at the University of Mississippi at Jackson. Brilliant guy. I mean, absolutely brilliant guy. But in his lab, they would clamp the renal artery of these mice, and just for a short period of time, and then release it, and they would all just go into pulmonary edema. So completely unrelated to anything they were touching anatomically, but that's from this crosstalk phenomenon. So when we have acute kidney injury, it isn't just that, they're not going to pee, or we got to worry about the potassium or any of that kind of thing. It goes well beyond that, and something that I think we need to be more involved with and paying better attention to. As clinicians, I think we haven't quite made the boat on this, because this is what happens. This is what you look like. And just look at those eyelids. They look like water balloons. And I've seen worse. I've seen patients who were 25, 30, 35 liters fluid overloaded, total body fluid overloaded, that didn't even look human. And few of them, there's been a few, but few of them live. Usually when you get that filled with fluid, you don't do well when you're critically ill and you're that edematous. And what's really important about this is when you look at this lady and you look at that water load, and you know that her hands are all puffy, her arms are puffy, her feet are puffy, she doesn't look good, the skin is tight, it doesn't look right, doesn't feel right, and we think to ourselves, yeah, that doesn't look good. But what I think we miss is what's illustrated in my next slide. That edema is inside as well as outside. Cerebral edema, myocardial edema, pulmonary, hepatic, increased renal venous pressure resistance, and renal interstitial edema. So it's a wonder the kidneys don't work. If the pressure on the outlet of the kidney is backing up, it's kind of like when you've got mitral regurgitation and it backs up into the lungs. It's the same concept. You back up the right side, well, you back up in the liver, and then you back up in the kidneys because they can't drain. And now you've really messed the thing up. So it's a very globally interrelated major problem when you have massive fluid overload. So there's a lot of studies, and I'll go over them, I think, in part 3, kind of right after we take a short break. But at the end of part, we'll go over some of these things and the data that really is pretty clear that drier patients do better. Now, you can't desiccate them. You can't make them look like Charles Chips and crunchy, because, they have to be able to perfuse, and you can't just, dry out all of their tissue, just have blood in the intravascular space and none in the extravascular space or in the intracellular space. But that's an extreme example, but drier patients do better. At the end of the day, that's what it's all about. And tissue edema, of course, I've seen patients who they've gotten compartment syndrome. I've seen patients with gut edema so bad, they get ischemic bowel, and then the lactate level starts going up. And then they have an infarction, and that's usually the end of the game. I've seen the belly so tight that it's blocked the venous return. So fluid overload kills at the end of the day. That's my message, okay? Fluid overload kills. And when you're giving saline or plasmolite as a resuscitative fluid, and it in total only lasts, the effect of it lasts for, is worth 250 cc's in the intravascular space, a very, very short half-life, and it ending up in the extravascular space, and you have to give more and more and more and more. That's why it's obvious. Edema is obvious when you're using non-colloids in order to keep fluid in the intravascular space or to improve the intravascular space, unless it's due to some other reason. For example, dehydration from being running a long race, or just having not had anything to drink for a while, or something like that. But when you're bleeding, or you're having volume shifts, or you have major changes in your oncotic pressure and have moved a bunch of fluid from your intravascular space to your extravascular space, and you're having to fluid resuscitate the intravascular space because its colloid oncotic pressure so low, your water is leaking out to the extravascular space, and you just give more water, you're exacerbating the problem each and every time you give more and more fluid. So it just gets worse and worse and worse and worse and worse and worse and worse. It will not get better. I don't care how much you give, it won't get better. Positive fluid balance is associated with worse outcomes in patients with acute kidney injury. You can see that survivors are in blue and non-survivors are in red, and the mean fluid balance in 24 hours, and that's across the board with acute renal failure, early acute renal failure, and in late acute renal failure. Fluid accumulation and survival in critically ill patients with AKI, fluid overload defined as an increase of 10%, a 10% increase in body weight compared to baseline. That's another thing we don't do well. That's the best way. If you have a good weight on the patient and you don't have a bunch of other stuff that hasn't been weighed piled up on the bed, or taking it that was on there and then taking it off and giving it the wrong number. If there's a way to do it and be accurate, it's the best way to measure the patient's fluid volume. There's no question about it in my mind. But nevertheless, you can see no fluid overload versus fluid overload, that your survival, your predicted survival is greater. These are statistically significant. And then percentage of dialysis days with fluid overload, so effective duration of fluid load on mortality. The more days you're fluid overloaded, the more likely you are to die. This is what I want to show you. This is a really interesting slide. So we talk about, and I'm kind of going to go back to the pump. So you're on pump. All right, and that's I'm a perfusionist, and I'm assuming that these are perfusionists mostly watching tonight. But you look there, and the head is obviously up. The right atrium is on the left side. This is the upper left panel, and you see the aorta is open, and you're looking down a tube graft there that probably looks like it was either a Bental, but it's going to be a valve conduit type of repair, ascending aorta repair. And then on the bottom left side, you see there's an oxygenator and a reservoir, all right, and we're on pump. The flow is only 2.7. I don't know. I didn't do this case. I'd flow more than that. I like most of my patients, but that's okay. They might have been coming down just for a second for a reason. But my point I'm trying to make here is when we assess volume in this must have been Patrick's case. When we assess volume on pump, and how much volume, we talk about ultrafiltration, we talk about wrap, we talk about these things, which I'm going to discuss some more. We look at these things and we go, well, my prime's only this much, and I'm going to wrap and whatever. But see that sucker? It's sitting in a big pool of water, saline, but it's irrigation. And that's coming to the pump because that is a pump sucker. You see the right atrium is completely flat. You see the mean arterial pressure is 67, and you see that the reservoir, which is an open style venous reservoir that they're using vacuum assist venous drainage on, it has got a certain amount of volume in it. I can't quite read it from here, but let's just say it's a liter and a half, 1,500 cc's. So let me go to the next slide, and then what we're going to do is, okay, so the prime was 1,200. Anesthesia gave 2 liters. We gave a liter of Del Nido. We've got irrigation, and we have unknown third spacing. Urine output consideration, loss through respiration in the ventilator, insensible loss through evaporation, blood loss into the laps and maybe the waste sucker, and of course the third spacing, of which we don't know to what degree. But let's take all of those things into consideration. So the blue that you see is the patient. The section to the right of that, where you see the little blue line on the bottom, is the reservoir. The orange, or whatever color brown that is, something similar to that, is the hemoconcentrator. And what will be the one to the right, which is going to be yellow, is going to be the removed plasma water. So the patient right there has a hematocrit of, let's just say, 30% for the sake of this argument, okay? So David, go ahead and let her rip. Now we just went on pump. And look at all that volume that we have. But notice that the right atrium is completely flat. And remember, I told you that these various nerve bundles, atrial natriuretic peptides, come from the right atrium. Brain natriuretic peptides, on the other hand, come from the right ventricle, but that's just equally as flaccid right now, right? So that's flat. Now, what do I do with that volume? Well, we could hope the kidneys put it out, but are the kidneys going to want to diurese or produce a lot of urine because the right atrium is now empty? So now there's a stimulus to hold volume, to say, whoa, I need to stimulate ADH because I need to stop antidiuretic hormone because I need to not lose any more volume. Even though I've got good flow here, because we're flowing, right? We're going through the renal artery, we're going through the afferent and efferent arterioles, but that right atrium and right ventricle are completely flaccid. So ANP and BNP are absolutely going, I'm empty. There's really shock. So let me ask you this. Let's just say there's some urine being made. It's, I don't know, 5 cc's per kilo per hour. Okay, so go to the next click. But I decide I'm going to ultrafiltrate that open reservoir. So when the right atrium the heart had blood crit of 30. After the priming volume and all the cardioplegia and everything else, it was down to 20. But I removed half of the plasma water, which again is isoosmotic. You're not removing any electrolytes selectively because I haven't given anything back to replace it. I haven't given a replacement fluid, but I have raised the hematocrit significantly. And that might be the difference between a transfusion and not a transfusion. And then what do I prime with? Do I prime with just crystalloid? Would I have primed this patient with blood? What if I just use straight crystalloid? Would I third space a lot more? Would RAP avoid third spacing? Is RAP worth it because you don't have that at least initial hemodilutional effect and a drop in your COP, your colloid oncotic pressure? I don't know. Is it worth? I don't think it is. I don't like RAP. I don't think that it's worth the risk that it brings of hypoperfusion to the brain and the other organs having to give pressors and manipulate things while I try to get this fluid off when I could just go on pump and ultrafiltrate it off. But the thing is, I hear people say all the time, no, if you ultrafiltrate on pump, you're gonna reduce the urine output. Why? Why? It should improve it. It actually should improve it, and I'll show you that with my next set of slides. There we go. Let's just look at it again. That is a cool animation. I really like that. Okay, so part 3 is going to be 2-albumin or not 2-albumin. That is the question. And so I'm going to take a short 10-minute break and then come back. We're going to talk about albumin and colloid and crystalloid replacement and kind of their effect. I hope somebody will call in. The phone's sitting right over here. I want you to, let's see. Tyler, Joe, I just wanted to take a moment to really appreciate the great information work. Wonderful people put the show. I'm absolutely fascinated, hooked on these conversations. Well, call me, Tyler. Call me. Call me on the phone so that you can be live online and on the air and be a part of this conversation. That would be fantastic. But I will tell you, Stephanie and you are still going to get a cup because you did make a comment. But I'd really like you to call in if you don't mind. And so with that said, let's go to a break. And when we come back, I'll do part 3. Okay, and welcome back to the program. It's great to see everybody back again. Let's go on right away to part 3, 2-albumin or not 2-albumin. That is the question. Another real controversial topic about albumin. I mean, I do a lot of ECMO as well as cases, and I know that many times in the ICU, we have to fight to try to give the patients albumin. Yes, it is more expensive. Like I said, it's about $40 for 25 grams, somewhere around there. But the effect of it is so much better. Each gram of albumin will hold onto or pull back into the intravascular space 18 milliliters of fluid. So for 100 grams of albumin, which would be about 200 cc's of 25%, you're going to, or even 400 cc's of 25%, you're going to have 2,200 cc's when you're done. Whereas if you give a liter of normal saline or plasmolite, you're going to have 250 cc's intravascularly when you're done. So you need to really take that into consideration when you're making these decisions about what to use for fluid volume. Another interesting fun fact of albumin is that if you are malnourished, and this is very interesting, just a 12 to 24 hour NPO, no nutrition at all, is enough to decrease synthesis of albumin from the liver by up to 50%. That's very significant because everybody having heart surgery is NPO and may very well also be malnourished. And if you're malnourished enough, in states of chronic malnourishment, your body, you will sacrifice muscle for energy and preserve albumin because albumin is 80% of the colloid oncotic pressure that's required in the blood to keep the blood volume, your intravascular blood volume, stable. So keep that in mind. These are all very interesting points. And I know that it's more expensive, but they say that they're concerned it's going to leak out because the half-life is about 90 minutes. And that's, that's not forever. You have to keep giving it, right? Which is understandable. But it's, unless you have a plasma leak, it's not going into the tissue, which would exacerbate the problem. So if you have a plasma leak, capillary leak, and you're leaking protein into your interstitium, you're in a whole lot of trouble. And so that's a whole different can of worms. Everybody that's septic, everybody that's critically ill, everybody that's really sick does not have a capillary leak. That's a very specific diagnosis. Now, I would say that very many people that we have see come to the operating room to have heart surgery are hypoalbuminemic for a variety of reasons. Excessive dilution from the cath lab can cause a relative hypoalbuminemia and hypooncotic state. It could be that they were just sick at home and didn't eat well, didn't have good nourishment, and they were hypoalbuminemic to start with. A whole variety of reasons. But, I think that albumin isn't really nearly as expensive as they say it is, given the totality of what we pay for things in the operating room and for the benefit that albumin brings. I think we need to be using way more of it than we currently do. And I think you're going to be fascinated with some of my slides and some of this data. Albumin is a natural colloid for perioperative fluid management. This is not an introduction to cardiac surgery from our perfusion colleagues. I know you already know what cardiac surgery is, but let's just indulge me a little bit, all right? Hypoalbuminemia is a predictor of poor outcomes in cardiac surgery. Albumin volume effect in cardiac surgery, we're going to go over that. Albumin for pump priming in cardiac surgery, its effect on platelets, fluid balance, clinical outcomes, erythrocyte crenation. Albumin for volume expansion in cardiac surgery. We're going to talk about its mortality, bleeding, and hemostasis as compared to crystalloid or perhaps other colloids such as gelatins or starches. Effects on renal function, comparison with Hess, and a summary and a conclusion. So that's going to be part 2 of this talk. So let's go over the introduction to cardiac surgery. Well, there are different types of cardiac surgery. There's coronary bypass, CABG, heart valve repair and replacement, implantation of devices to support heart functions, VADs, HeartMate 2, whatever, and heart transplantations. There are 2 general methods. There's the on-pump and there's the off-pump. And I'm going to show you that just because you're off-pump doesn't mean you don't need albumin. It's not the pump alone that needs albumin, though it helps the pump tremendously. But let's just keep moving forward here. They say aspirin is the miracle drug, and I do love aspirin. Okay, aspirin is a great drug, but I think albumin is equal to aspirin in terms of the many benefits that it brings. Again, very underappreciated. Nickel, we're being, I think, pound foolish and penny wise, or penny wise and pound foolish, I guess as that saying goes, penny wise and pound foolish when it comes to this. And would you all excuse me just for a second? I just need to excuse everyone for a second. Listen, I can't really concentrate too well. Thanks. Okay, thank you. I'm sorry. Let me come back online here. So risks of cardiac surgery potentially modifiable by fluid management: excessive bleeding, frequent, serious, and unpredictable. Many necessitate reoperation. Fluid overload, increased morbidity, increased mortality, increased length of stay in the ICU, hospital length of stay, ICU readmissions, and major postoperative complications. Renal failure, one of the major complications of cardiac surgery, incidence rate up to 30%, with 4% requiring renal replacement therapy. And again, I said this already, but I don't really feel that you can say someone is in renal failure just because there was a bump in the creatinine. And I'll tell you why I say that. It's not good that you had a bump in the creatinine. You may have had acute kidney injury, but you haven't had renal failure. I just think the definition needs to be changed. And I'll tell you why I say that. Let's say you're in renal, you say you really are in renal failure. Let's say your creatinine is 2.9, 3.2, and you're unstable, and your blood pressure is really tanking. We're going to give you what? We're going to give you a lot of crystalloids. So we pump you full of a bunch of crystalloids, and then we send a lab out. And the creatinine, oh, it's looking better. It's not looking better. It's diluted. A drop in creatinine can actually be an indicator of worsening condition. Think about that. But it's true, because we're diluting it, making something that's bad look better than it really is. Consider that next time you look at the creatinine. Systemic inflammatory response syndrome is increased. You have increased vascular permeability and poor microcirculation when you have that. So when you get SIRS, you're going to increase vascular permeability, we're going to leak more fluid, and you're going to have poor microcirculation. It goes around a lot of bridges, and you don't get good tissue perfusion. Hypoalbuminemia is a predictor of poor outcomes in cardiac surgery. Take a look at this retrospective study, looking at over 5,000 patients, consecutive cardiac surgery patients. 15% of patients were severely hypoalbuminemic. And that's a serum albumin of less than 2.5. I've seen them as low as 1.2 and coming in to have surgery and then arguing with people about, I need to prime the pump with more albumin. Oh, but it just doesn't help. There's no benefit. And I'll talk about the studies and stuff like that, because there are people that argue on the other side. And listen, there's a paper for everything. I can find you a statistic to prove my point anywhere, and you can find the opposite one anywhere. That's just the way it is. But let's take a look at it. Outcome. If death is favored by, is improved, you less likely to die with a high albumin. Acute renal failure, you're less likely to have. Re-exploration for bleeding, you're less likely to have to go back to the operating room. And ICU stays of greater than 3 days, you're less likely with high albumin. Preoperative albuminemia is an independent risk factor for multiple poor outcomes in cardiac surgery, and albumin administration may be valuable prior to cardiac surgery. So actually getting these patients tuned up with albumin before they come down, or improving their nutrition, giving them, amino acids, various different things to really help, because that's what helps. Effect of preoperative albuminemia on long-term survival after CABG. Take a look at this meta-analysis looking at 588 basically matched patients with propensity scores. 294 albumins were less than 3.5. 294 albumins were equal to or greater than 3.5. And you could see that the 8-year mean survival was higher in those patients with the higher albumin. So preoperative hypoalbuminemia of less than 3.5 independently predicted poor long-term survival after CABG surgery. Preoperative albumin administration may also improve long-term survival after CABG surgery. And I believe that that's because if you do that preoperatively, before you go on pump, treat it before, treat it on the floor, treat it in the ICU, treat it wherever, even before the pump. But let's say when you bring the patient to the operating room, you have less third spacing, less edema to have to deal with. But I think treating it on the pump is going to correct a lot of that if you're waiting all the way until you're actually in the operating room. Risk of postoperative hypoalbuminemia after off-pump cardiac surgery. Here's a retrospective study looking at 690 patients undergoing off-pump. Renal failure, need for balloon pump, reoperation for bleeding, use of inotropes, all favored high albumin. Postoperative hypoalbuminemia is an independent predictor for multiple poor outcomes after off-pump cardiac surgery. Albumin administration post-surgery may improve outcomes. So to you, Dr. Badia, if you're listening, I know you went to a Rockets game. I was actually invited. I was going to be invited by Dr. Badia to go to a Rockets game tonight. And I've never seen a professional basketball game live before. So I would have really enjoyed that. But I told him, no, I have to be here at the studio to be with you guys. So that's how important you all are to me. Just keep that in mind. So call, text, do something. Risk of postoperative hypoalbuminemia after CABG surgery. Retrospective study, 454 patients undergoing cardiac surgery with the pump. 28-day mortality. If the albumin level was equal to or less than 1.8 or greater, you can see the major difference there. And the same with it over in the duration of ICU stays in days. And I think it would have been real interesting to do that study and not do greater to or equal to 1.8 or greater than 1.8, but make it greater than 2.5. Make it a more dramatic thing. I think that was a little bit underpowered in terms of what they were looking for. But postoperative hypoalbuminemia is predictive of higher 28-day mortality. And I think what you're seeing there is, again, it's basically fluid resuscitation. It is a dilutional effect. If your albumin is 3, if I send you up to the ICU from the operating room after pump with an albumin of 4, I've treated it, and they don't give you any more, and they just give you 4 liters, 5 liters overnight of Crystalloid in order to give you a blood pressure and fluid resuscitate you, then guess what? Your albumin is going to be 2. And if it gets down to 1.8 or equal to or 1.8, it's an independent predictor of mortality. Not the right way to treat these patients. Albumin administration post-surgery may improve patient survival. Albumin volume effect in cardiac surgery. Albumin is more effective than saline for plasma volume expansion in cardiac surgery patients. Here's a randomized study comparing the effect of saline or 5% albumin on hemodynamic endpoints in 40 cardiac surgery patients. I realize that's a low-powered, pretty low-end number, but nevertheless, I think it's suggestive, and it's what I've seen anecdotally for most of my career. Albumin and saline had comparable effects on oxygen delivery and changes in interstitial and extracellular volume. You can see saline and albumin there increase in plasma volume as a percentage of volume was improved with albumin. 5% albumin is approximately 5 times more efficient as a plasma volume expander compared with normal saline in postoperative cardiac surgery patients. I think that's common sense. Hyperonchotic albumin is more effective than Ringer's lactate in plasma volume expansion. And you can take a look at these here. The takeaway to this, let's just go through the arrows. You've got 1,097 plus or minus 285 milliliters of whole blood withdrawn from a patient simultaneously, or from a subject, simultaneously replaced by 3-fold Ringer's lactate. So they gave 3,430 cc's. There was significant hypovolemia, decrease in blood volume, significant increase in interstitial water content, and Ringer's lactate volume effect was plus or minus 10%, only 17 cc's of the volume that was given. 245 plus or minus 64 milliliters of 20% human albumin was given and restored blood volume to baseline. Human albumin volume effect was 184 cc's versus the 245. So that's tremendous that you went from 3,400 cc's to 17 and from 245 to 184. I'll take those numbers all day long. It was done in a subject, and I'm assuming that it was, since it was a study and they gave 3 liters. No, I don't know the exact length of time. I'd have to pull the paper out and look at it. But I would imagine it's fairly short. But that's a good question. Thank you. Hyperoncotic albumin with a volume effect of more than 100% is a good option to recruit interstitial stored fluid towards the circulatory compartment. That's very important. So if your patient is already edematous and already hypooncotic, giving more fluid that exacerbates that hypooncotic state is only going to ending up in the interstitium even faster. You have to give something to pull it back. And remember, 1 gram of albumin, 18 cc's of fluid pulled back or held in the vascular space. That's important because if you give 100 grams and you pull back 1,800 cc's, and you give another 100 grams and you pull back another 1,800 cc's, say your patient's 10 liters fluid overloaded, that's all well and good. But if their kidneys aren't working really well, you better have a way to get it out. So I highly recommend you not do that unless you have CVVH or at least ultrafiltration or anything, simple ultrafiltration, but preferably with a CVVH machine readily available and functioning before you start resuscitating like that, because you can put them into, obviously, heart failure, hypervolemic congestive heart failure. Albumin for pump priming and cardiac surgery, what its effects on platelets, fluid balance, and clinical outcomes. Albumin is commonly added as constituent of pump priming fluid during cardiac surgery. I love it. I use it. I probably use more than most. Coats the fluid pathway surface, diminishing contact between blood and non-biologic surfaces. Now, that's only if you recirculate with the albumin, so you have to be careful not to run it all the way up the arterial line to where they make the connection, because when they're making the connection, it's real hard to get the bubbles out, and then they beat on it, and you get a lot of bubbles, and it just gets worse and worse and worse. So just the contact area minus that arterial line going up is a very helpful technique to avoid that problem. The aim is to determine the effects of pump priming fluid choice, albumin or crystalloid, on platelets, fluid balance, and clinical outcomes. The study design is a meta-analysis of 21 randomized controlled trials involving 1,300 plus patients undergoing CPB. The endpoints are platelet counts, COP, on-bypass fluid balance, postoperative weight gain, and colloid usage. Compared to crystalloid prime, albumin prime reduced on-bypass drop of platelet counts with a mean reduction of 23.8 times 10 to the 9th per liter, reduced on-bypass, oh, I'm talking too fast, there's a sign, thank you. The audience is telling me I'm talking too fast, so I thank you very much. Reduced on-bypass, I'm tired, positive, and everybody else wants to go home. They're watching. Oh, you guys online is watching? You're like, okay, Joe, wrap it up. Reduced on-bypass fluid balance with a mean reduction of 584 cc's, associated with a smaller reduction in colloid pressure, or COP. On-bypass was a mean reduction of 3.6 milliliters, and after surgery, 2.0 milliliters of mercury. Reduced postoperative weight gain, makes sense, because you're giving less fluid and it's holding less. Mean reduction was 1 kilogram. Reduced postoperative colloid usage was a mean reduction of 612 milliliters. As albumin prime has a more favorable effect on peri and postoperative outcomes in cardiac surgery with CPB compared with crystalloid prime, albumin is a preferable option for pump priming. I love Russell et al. Albumin for pump priming in cardiac surgery effect on erythrocyte crenation. I didn't even know this. Albumin prevents erythrocyte crenation in patients undergoing extracorporeal circulation. Free fatty acid-induced erythrocyte crenation has been reported in patients undergoing CPB. Crenated erythrocytes are thought to impair microcirculatory flow and tissue oxygenation. I mean, that's kind of intuitive. Controlled study of 38 patients undergoing CPB with 0, 25, and 50 grams of albumin in prime solution were reviewed. And if you look at the bottom, you see on the left, before CPB, you have nice, regular-looking biconcave enucleated disc like a normal erythrocyte is supposed to look like. During CPB with no albumin prime, you can see those same red blood cells looking very irregular, crenated, scrunched up, looking bad. And on the right, during CPB with 2.9% of albumin prime. So 3% of your prime was albumin. And this is studying 0, 25, and 50. I'd like to use 100 grams in my prime, frankly. But you can see on the right side of the graph, and there was statistical significance to this. Erythrocyte crenation almost completely prevented by administration of 50 grams of albumin, and was protective effect of albumin due to binding of free fatty acids. I didn't even know this. I've just recently learned it. I think it's pretty exciting stuff, just to get another a good reason to use more albumin. Albumin for volume expansion in cardiac surgery, its effect on mortality, a database study of 19,578 cardiac surgery patients. And if you look there, odds ratio, if lower risk of death when you use albumin use versus synthetic colloids. So synthetic colloids didn't have the same benefit as albumin, a naturally occurring substance. Made a difference. Patients who received albumin had a lower incidence of mortality than those who received synthetic colloids. In multivariable analysis, the mortality rate was 25% lower in the patient group receiving albumin compared to those receiving synthetic colloids. And approximately 5 to 6 lives were saved for every 1,000 patients who underwent CABG surgery when albumin was used rather than synthetic colloids. And I'm not going to get into it at this point in time, but albumin was associated with lower risk of death after CABG. But let's go back to what I wanted to talk about, which is the gelatins, the albumin versus the gelatins versus the starches like Hespan, head of starch, and that kind of thing. Look, surgeons are given that stuff when they do carotids to reduce the risk of thrombosing their carotid endarterectomy, their patch, their carotids, decreases clotting. And so, we do coronary surgery, we do valve surgery, you do a type 1 dissection, you do a Bental, you do a left ventricular aneurysm, or you do a double valve CABG procedure, whatever it may be. The last thing you want to use is a substance that increases bleeding. So postoperatively. So that's the problem. I think they're good for non-bleeding volume replacement. I don't really feel they have a good place in cardiac surgery. And I think they do have a place, for example, in vascular surgery like endarterectomies, where you want volume expansion but decreasing the thrombotic risk of the surgery that you did if you have a patch or something like that, like in carotids. Albumin for volume expansion in cardiac surgery, its effect on hemostasis. Well, I just sort of went over that, I guess. A summary of 2 studies. Albumin, there was no change in the coagulation time. With gelatins, there was no change either. With Hess, the 2 iterations of it, there was an increase in clotting time. Clot formation time was not changed in albumin. It was increased with gelatin and really increased with the Hesses. And clot strength was not changed with albumin, but decreased with both the gelatins and with Hess. Albumin is preferable for volume expansion in patients undergoing cardiac surgery, as unlike gelatin or Hess, it does not impair hemostasis after CPB. Albumin effects on renal function. Now, we talked about the kidney already. We're going to talk about it yet again. So, in this meta-analysis, effects of hypertonic albumin on AKI, the aim of the study is to compare the effects of hypertonic albumin or Hess on AKI. It is a meta-analysis of randomized controlled trials. The studies included and evaluated AKI following infusion of hypertonic colloid versus control crystalloid. That's hypertonic colloid being albumin. 4.5% hypooncotic albumin and no fluid. It was 20 to 25% albumin in 77 studies, 10% Hess in 4 of the studies. Patient N was 1,220, 1,220. Population surgery, 3 studies. Patients being treated for ascites, 4 studies. For spontaneous bacterial peritonitis, 2 studies. So a very sick patient. That's a very sick patient. Severe sepsis or septic shock, 1 study. Early septic shock, 1 study. And does hypertonic, so the primary endpoint is, does hypertonic albumin or Hess increase AKI risk versus control? And the secondary endpoint was death. So here you see on the left side, you see pooled incidence of AKI or acute kidney injury in a percentage. In the control, much, much, much higher, statistically significant than in the albumin group. Further evidence that albumin may have beneficial effects on renal function. Albumin can be thought of as having renoprotective effect. It preserves renal function even in patients with pre-existing kidney abnormalities. Albumin is the only colloid in which renal safety is supported by a large, multi-center, double-blind, randomized controlled trial in critically ill patients. And you can't get any more valid, if you will, than a large, multi-center, double-blind RCT. That's it. That's the gold standard of all research. A recent study comparing chloride liberal with chloride restrictive intravenous fluid administration in critically ill patients demonstrated that a chloride restrictive strategy with 20% albumin was associated with a significant decrease in the incidence of AKI and ARF, and again, statistically significant, and the use of RRT, renal replacement therapy. So again, statistically significant decrease in the use of all of that, including the need for renal replacement therapy, which decreases costs. So, this is all, we go round and round with this. Well, albumin is more expensive, and, well, renal replacement therapy is expensive. Okay, so if you could prevent renal replacement therapy, you're saving money here by spending money there. That's such a difficult concept for administrators to understand, but it is what we deal with. But I think that in this case, it's very, very, very real. I don't know why so many intensivists and pulmonologists are so anti-albumin. I will show you a study because I have to be, fair. And show you the other side of this whole argument to some degree, but I am very heavily biased. I am a big believer in albumin, and I think that the data is much stronger in the pro-albumin side than the restrictive or lack of use of albumin for a whole variety of reasons. Summary and conclusion. Volume expansion in cardiac surgery. Albumin is significantly more efficient than saline as a plasma volume expander in cardiac surgery patients. Albumin is associated with better bleeding outcomes after CPB compared to Hess. I mean, I don't even think any of us use Hess span anymore, but It still exists. Albumin does not impair hemostasis after bypass compared to, again, the Hesses or the gelatins as a colloid. Albumin has been shown to have beneficial effects on renal function and decrease in inflammation. Hess has been shown to have detrimental, that's true. Albumin is preferable to synthetic colloids for volume expanding, for volume expansion. Pump priming in cardiac surgery, albumin is associated with better clinical outcomes compared with crystalloids. As a colloid, albumin has the advantage of maintaining COP and reducing edema. Albumin avoids the complication of fluid overload associated with crystalloids. And again, fluid overload, not just intravascular fluid overload, but total body, whole body fluid overload. Edema, third spacing, the bad stuff that hurts everything else. Albumin, in my opinion, and from these studies, is preferable to crystalloid for pump priming. Albumin is the fluid of choice for cardiac surgery. Now, albumin use guidelines and outcome in a surgical intensive care unit. This article from Arch Surgery in 2008, in the first quarter, the number of patients was 356. Albumin use unit of 12.5 was 813 different bottles of 25%, that's the 50 cc bottles. Albumin cost was $34,000 at $43 per vial. Mean ICU mortality was 4.62%. Predicted ICU mortality was 6.43. Apache 3 score on day 1 was 46.6, and the mean ICU length of stay was 4.29. So let's just kind of distill this down and not go over each line. I'll drive y'all crazy. The number of patients in each quarter was roughly the same. The amount of albumin used each of those quarters was less and less and less, getting down to almost half. The cost to the hospital was $34,000 when it started in quarter 4, down to $19,000. The mean ICU mortality actually improved in this study. The predicted ICU mortality was the same throughout, basically the same throughout the study. The Apache 3 score was essentially the same throughout the study, and the mean length of stay in the ICU was essentially the same throughout the study. So what they concluded was that the use of albumin did not benefit in ICU mortality or in length of stay, but did cost more money. So the question that I have for these researchers is, did they, or these clinicians, did they use the albumin correctly? Or did they just use it kind of willy-nilly? I'm going to give a bottle now, and I'm going to wait until, and we're going to give 12.5 grams, and then we're going to give 12.5 grams again in 6 hours, and then we're going to give 12.5 grams again tomorrow until we've used up whatever amount we're going to use. Well, that's not really treating it. If your albumin level is 4, you don't need it. If it's 5, you really don't need it. If it's 3, you need some. If it's 2, you need more. If it's 1.2, you need a lot. You have to correct it. That's not what they did. So, I think that if you're going to design a study to evaluate cost benefit, then you have to use the drug or use the solution or use the product in a way that maximizes its effectiveness and benefit. That's my perspective on this paper, which purports to say albumin is not beneficial. Okay, so it's all about what goes in needs to come out at the end of the day. So I want you all to just take a few minutes. I want you to look at that kid and wonder to yourself, how's that cereal? Is it good?